Vasilios, first of all, good afternoon. And Vasilios, thank you very much for your so kind invitation and also hospitality extended in Porto Heli. I am visiting for the first time. And also thank you very much for identifying the title of my talk today, which is New Phenotypes of Arterial Hypertension. And also, I decided by myself to identify this topic since I was co-authoring the new 2023 European Society of Hypertension guidelines, and together with Professor Kreutz, Professor Mancia, we work extensively on the identification of new phenotypes of hypertension. And this is one of the novelties of our guidelines. And please note that based on the and thanks to the wide use of out-of-office blood pressure measurements methods, and also due to the better understanding of complex pathophysiology of hypertension, we may currently identify at least 5 new phenotypes of hypertension. And today, I will focus on true resistant hypertension, isolated systolic hypertension in young. Then I will briefly follow to masked hypertension, isolated nocturnal hypertension, and finally malignant hypertension. I will be not focusing on other types, other phenotypes of the disease, for instance, related to oncology treatment in patients with normotension or with pre-existing hypertension. I will start from true resistant hypertension. This term of true resistant disease was implemented for the first time in our guidelines. And please note that resistant hypertension is a worldwide problem, and based on one of the biggest meta-analysis, which included 3.2 million of treated hypertensive patients, we know that all over the world, across continents, the prevalence of resistant hypertension is within the range of 10–11%. And as mentioned before, we do not see any particular differences between United States, European countries, Asian countries, or African countries. Also, please note that the prevalence of resistant hypertension is increasing, sometimes dramatically, in patients with chronic kidney disease after renal transplantation, and of course is rising with age. However, this is one problem involved in this meta-analysis, since it is mostly focusing on apparent hypertension. And please note that our European Society of Hypertension guidelines introduced a very strict definition of resistant hypertension and also particularly of true resistant hypertension. And please note that two conditions should be fulfilled. First of all patients with apparent hypertension diagnosed based on office blood pressure measurements should undergo ambulatory blood pressure monitoring, or alternatively home blood pressure monitoring, and we may then confirm so-called true resistant hypertension. So the prevalence of this phenotype of hypertension is much lower than if reported in the presented meta-analysis. And we assume, and this is included into our guidelines, that the real prevalence of true resistant hypertension is ranging from 2–3 and is not exceeding 4–5%. And also, I will touch this problem in a second, we should also rule out, to confirm true resistant hypertension, most common forms of secondary hypertension. The question arises, why we are differentiating between true resistant hypertension and apparent or white coat hypertension? Please note that true resistant hypertension is definitely a new phenotype of hypertension characterized by a much more pronounced target organ damage, and also the number of coexisting cardiovascular diseases, renal diseases, is much higher in patients with true resistant hypertension as compared to those with white coat hypertension. And also, please note, based on a very meticulous study, prospective study, that also patients with resistant hypertension, particularly those with true resistant disease, are characterized by increased risk of developing both renal outcomes and renal failure in the long-term observation, including 4 years, as compared to non-resistant, well-treated hypertensive subjects. The kidney function is also clearly discussed in our, extensively discussed in our ESH guidelines. And please note that the mode of treatment of patients with true resistant hypertension at steps 3 definitely depends on renal function. And for instance, with those with GFR higher than 30, we may safely implement spironolactone, which is contraindicated in patients with lower GFR than 30, and then we would prefer chlortalidone combined with loop diuretics. And finally, I also mentioned that in patients with apparent hypertension, we should rule out to confirm true resistant character of the disease most common forms of secondary hypertension, and there is no doubt that a hallmark of resistant hypertension is primary aldosteronism, and vice versa. Resistant hypertension is a signifier of primary aldosteronism, and please note it is a lower graph. The results of Torino study performed in Italy by Paolo Mulatero and his colleagues, and this study clearly showed and was performed among general practitioners that the prevalence of primary aldo is definitely related to the severity of hypertension, and the prevalence of primary aldo within the whole cohort of hypertensive patients were dramatically increasing up to 12% in patients with true resistant hypertension. And also we should remember that also atherosclerotic renovascular disease and renal artery stenosis due to fibromuscular dysplasia, these two causes may definitely lead to the development of resistant hypertension. And finally, I would like to answer the question why resistant hypertension, and in particular true resistant hypertension, is a hallmark of increased cardiovascular risk in patients with resistant hypertension. And the answer comes from the REACH registry involving almost 54,000 patients with hypertension. Almost 13% of them were resistant. And please note that patients being taken on 3 and more antihypertensive drugs were of the highest and still increasing risk of cardiovascular events and stroke. And also this explains how the definition of resistant hypertension assumes and supports with the number of 3 and more antihypertensive drug being taken by patient who is resistant. So taking together, we should keep in mind as a clinicians the patients with true resistant hypertension are, in my opinion, of the highest cardiovascular risks. Now I would like to switch and to tell a few words about isolated systolic hypertension in young. We know that isolated systolic hypertension is also a hallmark of the hypertension in the elderly, and also a few years ago, a new phenotype of hypertension being prevalent in young was identified as isolated systolic hypertension. Isolated systolic hypertension in young is characterized by increased both peripheral and central systolic and diastolic blood pressure, and also is characterized by increased pulse pressure, both evaluated by peripheral and central systolic and diastolic blood pressure measurements. Please note that one of the signifiers of isolated systolic hypertension in young is increased arterial stiffness along with increased activity of renin-angiotensin-aldosterone system and sympathetic nervous system, and also several studies, I'm presenting one of them, clearly showed that obesity is very often associated with the isolated systolic hypertension. The prevalence of this phenotype of hypertension is ranging from 2 up to 12% of hypertensive patients in young. And please note that based on a huge meta-analysis of more than 6.4 million hypertensive young patients aged 20 to 39 and not taking antihypertensive medication, we learned that in young adults, particularly stage 1 and also stage 2 of isolated systolic hypertension in young was associated with a higher cardiovascular risk as compared to normal blood pressure or to stage 1 of diastolic hypertension. And also, if we may translate this study into clinical practice, and we learn from this project that categorizing young adults with one stage of isolated hypertension may improve and increase the accuracy of risk stratification for identifying those young patients of higher cardiovascular risks. So taken together and returning to our European Society of Hypertension guidelines, we should remember that if a young person with isolated systolic hypertension is hypertensive and his systolic blood pressure is selectively increased and also he is of higher cardiovascular risk and he's manifesting hypertension-mediated organ damage, we should put such a patients into blood pressure lowering drug treatment, particularly when central blood pressure, both systolic and diastolic, is increased, and also if ambulatory blood pressure or home blood pressure measurements are clearly indicated the isolated systolic hypertension. Let me now move for a moment to mask hypertension, and this ABPM clearly explains what is so-called masked hypertension. In a few words, in practice, masked hypertension based on this ABPM profile is a normal blood pressure during or lower blood pressure, both systolic and diastolic, during ambulatory visit, and then both systolic and usually also diastolic blood pressure are rising, and the patient is definitely hypertensive. We know from Professor Guido Grassi study that masked hypertension is being characterized by marked sympathetic overdrive and also by metabolic abnormalities. And again, one large study clearly showed that those patients with mask hypertension, as compared to those with normal blood pressure, are characterized by increased cardiovascular risk, and also what is shown on the right part of the slide, they are also characterized by more pronounced target organ damage, particular LVH, as compared to normotensive subjects. So in conclusion and in summary, based on our ESH 2023 guidelines, we should remember the particular after time study that blood pressure lowering drug treatment should be used in patients with mask hypertension. Particularly should be considered strongly in patients with mask hypertension coexisting with target organ damage and high or very high cardiovascular risk. And currently, the next identified phenotype of hypertension, isolated nocturnal hypertension, characterized by selectively increased blood pressure during the night, and patients with isolated nocturnal hypertension are characterized by normal values of systolic and diastolic blood pressure during the day. Our guidelines and also 2021 ESH practice guidelines for office and out-of-office blood pressure measurements, they are strongly recommending to identify those subjects with isolated nocturnal hypertension. We know that one of the key mechanisms being involved in the pathogenesis of isolated nocturnal hypertension is increased sympathetic nervous activity, particularly in those patients with coexisting obstructive sleep apnea, which is again a hallmark of isolated nocturnal hypertension. And again, in this form, in this phenotype of the disease, we have evidences from clinical studies that isolated nocturnal hypertension is associated with increased mortality and all cardiovascular events as compared to those subjects with normotension or stage 1 hypertension. And, as mentioned before, after time study, we may propose that patients who with identified isolated nocturnal hypertension at night should be put on antihypertensive drugs, particularly when manifesting target organ damage. And we know that switching from morning to bedtime dosing is safe, what was documented by the time study. And finally, the last phenotype of hypertension, which is, in my opinion, one of the most important in the field of hypertension, is so-called malignant hypertension, which is currently and over decades identified as a severe hypertension, as a hypertensive emergency characterized by dramatically increased, particularly diastolic blood pressure associated with bilateral retinopathy, and some guidelines are also recommending to add impaired renal function. However, in our very recent review article, which we published together with Franz Messerli and other colleagues from Europe, we clearly advocating to change the definition of malignant hypertension from what is named malignant hypertension to hypertension with multi-organ damage, since we know, and it is documented in one of the ongoing studies, which will be shown in a moment, that malignant hypertension is not only characterized by acute microvascular damage and autoregulation failure, but almost 90% of patients with malignant hypertension are also characterized by dramatic changes in the brain, heart, kidney, and the whole vascular tree. Therefore, there is a proposal to change the definition from malignant hypertension to hypertension with multi-organ damage, affecting brain, affecting heart, affecting kidneys, and the whole vascular tree. Please note that malignant hypertension usually recognized as a completely vanishing entity, almost non-existing, is definitely present. And please note that the prevalence of malignant hypertension, based on the very recent American and European studies, is not falling, but it is decreasing, particularly within immigrants from Africa, Asia, and other continents. Also, please note that, and what was stressed in our review article, that also, we have to change the attitude, the approach to the treatment of malignant hypertension. Of course, during the first 24-48 hours, the patient should be admitted to the emergency unit, but also we should remember that taking care over the patient with malignant hypertension, we should also take into consideration all coexisting cardiovascular complications and also cardiovascular diseases. And finally, please note that the knowledge, the clinical characteristics of patients with malignant hypertension has been dramatically changed and improved thanks to the ongoing HAMA study, which is a multi-center study ongoing in France, driven by Dr. Romain Boulenstro in University of Bordeaux in France, and also two European countries, Poland, our Department of Hypertension in Warsaw, and also the clinical center, hypertensive clinical center in Italy, headed by our colleague Maria Lorenza Muezan, is also involved in this project, and we both we are collaborating with Dr. Romain Boulenstro. So please note, and in summary, that based on the very recent HAMA study, we may identify completely and revisit completely new one phenotype of hypertension, which is malignant hypertension, and which is basically associated with multi-organ damage, the most dramatically pronounced in the field of cardiology. So thank you very much, Vasilios, for your so kind invitation. And finally, as a closing remark, I would like to invite all Greek colleagues to Gdańsk in the north of Poland in 2026, together with Professor Chris Narkiewicz. We are both presidents of the 2026 European Society of Hypertension meeting, which will be for the first time held in Poland in a beautiful city of Gdańsk. Thank you very much for your attention.